I do want to just start by acknowledging where I'm calling from today, which is the University of Guelph. And the university is located on the treaty lands and territory of the Mississaugas of the Credit First Nation of the Anishinaabe peoples. And this land is part of the Dish with One Spoon, a covenant between Indigenous nations to live in peace on the territories of the Great Lakes. Today, this gathering place is home to many First Nations, Inuit, and Métis peoples, and acknowledging them reminds us of our collective responsibility for this land. And as I said, I will talk a bit about my background, but I just want to start by sort of recognizing the title of this talk. And it's always, I find, a bit challenging to figure out what to say in this type of seminar because the options are quite vast. And I think when Matt and Sadeep initially asked, the request was to present my research on AMR and in zoonotic disease, as well as share my experience in One Health. And I hope what I've put together today does some of that, but I also hope that it will take you through sort of my journey in thinking about humans and animals, diseases and health, and how my thinking in those areas have changed over the last 20 or 25 years or so. With that in mind, I'm going to start with this background. I am a veterinarian and I grew up in British Columbia on the west coast of Canada. And because of that, I went to vet school at the University of Saskatchewan on the Canadian prairies. After that, I spent about 3 years in a mixed animal practice on Vancouver Island, being a vet that you typically think about, seeing dogs and cats and horses and cows. But after about 3 years, I was ready for a change, and I wasn't sure what that change was. But I reached out to some previous professors of mine at the University of Guelph, or who were now at the University of Guelph, and they were encouraging veterinarians to come back for graduate school, and so off I went. And so I joined the University of Guelph and completed a PhD in 2005. And since that time, I've worked for a variety of organizations, including the Centre for Coastal Health, the Public Health Agency of Canada, and the Canadian Wildlife Health Cooperative. And I'm going to touch on what each of those are and what they meant to me. And so I did that for about, 15 or 18 years. And then in 2019, I joined the University of Guelph in one of their new One Health positions. And so this idea of disease and health has followed me throughout my career. And I do want to just sort of orient it with some of these triangles. And this is an idea I've borrowed from Carl Ribble, who was my PhD supervisor and longtime colleague. But in disease and epidemiology, we often consider this classic kind of epi triangle of host, agent, and environment. And how these factors combine determines where, when, how, and who a disease might emerge or spread. And in health, or at least in One Health, there's this other triangle of human, animal, and ecosystem health. And depending on how these three pillars kind of interact, health can be maintained and promoted, or perhaps demoted and lost. And what I'm going to spend most of my time on today is my sort of walking through that orange arrow from thinking about really focusing on disease to really thinking about how we can promote health better. And I worry in making this transition from disease to health that a lot of us have simply crossed out the word disease and inserted the word health without really considering what those words mean and without, I believe, usually changing what we're doing. And in trying not to do this, I've gone back to the definitions of health and disease more often than I care to admit. And the things that I need to constantly remind myself of are that disease is something much more than infectious disease. And health is so much more than the absence of disease. And where I've landed is some of the newer definitions coming out of international organizations like the WHO, recognizing health as this capacity to cope with change and enabling us to take on and absorb some of those threats that are coming at us from multiple directions these days. So with those definitions and that little bit of background about myself in mind, what I'd like to spend the next, 30 or 40 minutes or so on is walking through that journey from disease to health. And I'm going to start by looking quite a ways back in time at where my professional career started and has taken me so far. And I'll go back as far as my PhD at the University of Guelph, working on enteric disease in the province of Alberta. And this was my research question there on the screen. Is the incidence of zoonotic enteric disease high in southern Alberta? The question very much grounded in disease. But my pathway to grad school started much further back than that. I loved my epi classes in vet school and was fascinated by infectious disease for a long time. And I read all sorts of books, and you can see some pictures of some of those books on there. Most of them are about disease and our ability to control them or regulate where and when they happen. And I also had a long-standing fascination with the North. So between my second and third year of the vet program, I worked in a vet clinic in Whitehorse in the Yukon Territory. And the big takeaway message for me that summer was that I had to take the eco-health course in my final year of vet school. And that's a rotation that's still happening today. And it brings together vet students from the 5 different vet schools across the country to work on a variety of complex health problems. And although I didn't know it at the time, that course opened up a whole bunch of doors for me, and in particular introduced me to the Center for Coastal Health that I'll come back to in a moment. But coming back to my PhD work, I never really did answer that question of whether incidence of enteric disease was higher in southern Alberta, mainly because the answer depended on what data sources we were using and on what scale the analysis was done. But it did give me a great opportunity to develop a solid understanding of disease surveillance, the importance of scale and context, and an appreciation for the many factors that affect our interpretation of data, and that also influence the occurrence of enteric disease. After finishing my grad work, I then went back to British Columbia and worked for the Center for Coastal Health, in large part because of those connections I made on that eco-health course. The Center for Coastal Health is an independent nonprofit organization whose mission is to identify and understand the interactions of human, animal, and environmental health. And many of the projects I worked on at the Center for Coastal Health were very much focused on disease in animals and the potential threats that diseased animals pose to humans and the local ecosystems. Most of our projects were sort of issue-driven. So we did things like help coordinate surveillance programs for West Nile virus, avian influenza. We did a whole bunch of risk assessments for different diseases, and also for invasive alien species like the American bullfrog that is not native to British Columbia, and the importation of novel sort of livestock species like the Pacific oyster. But regardless of what the topic was that we were working on, what we actually did was pretty much always the same. We talked to people, we brought different players to the table and worked to come up with solutions that were agreeable, at least to most. And I'm not sure we were always super successful at this, but it was through this process and through the projects that I took on at the Center for Coastal Health that my thinking about health and disease really started to evolve. So after about 4 years with the Center for Coastal Health, I moved back to Ontario, where I am today, and started working for the Public Health Agency of Canada, and specifically for the Canadian Integrated Program for Antimicrobial Resistance Surveillance, or CPARS. For those who aren't familiar with CPARS, it's a unique antimicrobial resistance and use surveillance program that was designed from the get-go to be integrated, to bring those pieces together. It's similar to NARMS, the National Antimicrobial Resistance Monitoring System in the US. And what CPARS does is monitor trends in antimicrobial use and resistance in selected foodborne bacteria from humans, animals, and food sources across Canada. The information that CPARS generates can help inform policies and control antimicrobial use in different settings, and identify appropriate measures and places to intervene to help contain the emergence and spread of antimicrobial resistance. To me, CPARS is an excellent integrated disease surveillance program that also provides a robust framework to support all sorts of different research projects. So we have our baseline surveillance, and then we sort of add on various research projects that vary and change over the years. The managers and directors at CPARS are regularly asked about the connection between antimicrobial use in animals and human-resistant infections. And for me, the answer to this question really remains, we don't know, or we don't have a good answer for it. And again, it depends. That dependent thing, that context piece really comes into play here as well. And it depends because the connection is really different for different bacterial species, for different antimicrobials and their various mechanisms of action, and for different livestock and poultry host species that we might be considering. But it's in working to better answer some of those questions that I listed there on the right-hand side of the screen that got many of us thinking more about One Health and antimicrobial resistance. And integrating surveillance data is actually quite hard. And because of this, in the CPARS reports and various reports from other surveillance programs that are quite similar, we tend to report resistance and use data separately. And we report different sectors separately as well. So there's a section on humans, there might be a section on chickens, there might be a section on pigs. And when we do integrate the data, we often simply put the different data sources on a single figure, which is kind of what I'm showing you right now. And I'm going to spend a little bit of time on this slide because I think it tells a really great story about disease and some of the actions we can take to reduce disease. So by way of background, ceftiofur, which you can see that I've titled this chart here, use of ceftiofur on farm. So ceftiofur is a third generation cephalosporin. It is not used in people, but it has a wide variety of approved uses in livestock species. And it's used in those livestock species to treat a wide variety of infections. A very similar drug called ceftriaxone is also a third generation cephalosporin that is widely used in people to treat, again, a wide variety of infections, including salmonella infections if they're complicated. If an isolate of salmonella or other organism is resistant to ceftiofur, it is also typically resistant to ceftriaxone as well. And so that reduces some of our options for treating complicated salmonellosis in humans. Although ceftiofur is approved in a wide variety of livestock species, it has not been approved for use in domestic poultry. That said, we use a lot of the antimicrobials in veterinary medicine that are off-label, simply because there's not that many products and diseases that have labeled applications. And so ceftiofur was used in poultry production to control yolk sac infections in really young chicks. And so the drug was injected into the eggs at the hatchery at around 18 days of incubation. And it was used to prevent omphalitis or yolk sac infections in those young chicks. And yolk sac infections are usually due to E. coli. So that's sort of the background. And then on this slide, if you look sort of at the far left, you can see a gray line, a yellow dashed line, and a sort of an orangey red line. So the gray line is retail chicken. So it's the portion of salmonella isolates that we recovered from chicken that you would buy at the grocery store that were resistant to ceftiofur and ceftriaxone. The yellow line is isolates of salmonella taken from chickens at slaughter plants that were resistant to ceftiofur. And then the reddish line are the human salmonella isolates that were resistant to ceftiofur and ceftriaxone. And so CPARS is about 20 years old. And when their first report came out in around 2004, it showed very high a very high proportion of salmonella isolates that were resistant to ceftiofur, particularly in the province of Quebec. And we also saw a high proportion of salmonella from humans, specifically Salmonella heidelberg, that were also resistant to ceftriaxone. And this report triggered some actions in the province of Quebec in that poultry hatcheries banned the use of ceftiofur to control yolk saculitis in their chicks. And it wasn't just hatcheries in the province of Quebec that took this action. Several hatcheries across the country stopped using it as well. And what you can see is that when use stopped, we see this big drop in resistance. And we don't have a ton of good use data going back this far, but we did have some anecdotal evidence and data to support the claim that the drug was not being used very widely. That carried on for about 2 or 3 years. We saw very low levels of use, And we saw very low and ongoing declines in resistance in both poultry isolates and salmonella isolates from people. But remember, those poultry producers were using the drug for a reason. And that reason was still there. They were still losing chicks to yolk sacculitis. And so after a couple of years, they returned to partial use to of ceftiofur. And it was partial use in that they were trying to alternate the use of ceftiofur with other drugs in hopes of reducing the impact of resistance. But as you can see, between 2008 and about 2011, we saw a sort of an ongoing rise in the level of resistance in both chicken isolates and in isolates from humans. At around the same time, the poultry sector in Canada got a ton of negative media attention. And so there were several articles written in the Canadian Medical Association Journal. There were several exposés sort of in our national newspapers and on the television as well. So the poultry industry was having some pretty negative media attention paid to it. And it was probably a combination of all of these factors and changing consumer preferences that enabled CPARS, that surveillance program, to start their on-farm surveillance program. And so in 2013, we launched farm surveillance of poultry. And you can see that blue line there at the end. And as part of that farm surveillance, not only did we have isolates that we knew were resistant or what proportion were resistant, but we also had information about drug use on farm. In part because of recognition of the correlation between use and resistance for the ceftiofur story, and probably because of the negative media attention, the poultry sector in 2014 banned the use of all Category 1 antimicrobials for preventive use in poultry. And Category 1 antimicrobials in Canada are those of very high importance to human medicine. And ceftriaxone and ceftiofur, as third-generation cephalosporins, fall into this category. And so as of sometime in May of 2014, poultry farms could no longer use these drugs for disease prevention purposes. And we've seen none of them report that use since that time. But I don't have a slide. But remember, they were using it to control the disease. And other than changing their use practices, very little else in the industry had shifted. They were still sourcing chicks from the same places. They were still growing the birds in the same facilities, and they were still marketing them at the same weight and price point. And so instead of using ceftiofur, they simply changed to another category of drug. And then we saw resistance to those new drugs going up as well. As of May 2018, the poultry sector has banned the preventive use of those antimicrobials as well. And they are currently planning to ban all preventive use of medically important antimicrobials. And they haven't committed to a date, but it's not that far off. And that, I don't know what's going to happen when they stop use or preventive use. I don't know how that's going to affect or shift how the industry raises birds. But I think the ceftiofur story, one, is one of the only, it's one of a small number of studies that provide evidence of a connection between use in animals and resistance in people. And it's really sort of forced the issue us to think a little bit more about the issue in how we use medically important antimicrobials in agriculture and for agricultural production purposes. So I know that was a lot. Essentially, it's just a really good accidental but controlled experiment where we have high use, high resistance, low use, low resistance, increasing use, increasing resistance, decreasing use, decreasing resistance. So it does provide some nice correlation. And a colleague of mine, Lucie Dutil, was able to demonstrate that correlation for the province of Quebec in her 2010 paper. And I think the ceftiofur story is just a great example of those connections, as I mentioned, between human and animal disease. We have chickens that are sick, where use of antimicrobials is effective at controlling the disease, but that use selects for resistant organisms that can move through the food chain, thus exposing humans to resistant organisms, some of which may go on to cause disease. And this simple figure here on the left is how we often think about AMR, I think, through the food chain, from animals to food to humans, also recognizing that there are other routes through which humans can be exposed to AMR and the important role of human antimicrobial use to the system also. But we know these connections are not unidirectional. We also know that food is not the only way that antimicrobial resistance moves between animals and humans. Direct contact and environmental spread are also important connectors. But even this doesn't capture the complexity of the system from which AMR emerges. And it was in thinking about the Cephalosporin story that I just described that myself and other colleagues first started thinking about antimicrobial resistance as a product of a complex adaptive system. And I know you can't read it, that's okay, but the simple base model on the left is embedded sort of in the middle or at the core of this mess. And to start building this diagram, we challenged ourselves to really identify the drivers, those root causes of resistance. So for example, we started with antimicrobial resistance or use on farm. Why are antimicrobials used on farm? To treat or prevent disease. Okay, so what contributes to disease occurrence on a farm? It might be housing or stocking densities. It might be source of the livestock species. And what drives those decisions? It might be economics, it might be certain sort of trade policies, it may be farming tradition in your area. And as you move back and back, you can see how it quickly becomes connected, and there's a whole bunch of different arrows there. And to put this one together, a small group of us spent some time in a room just sort of scribbling arrows and different nodes. But we were all vets and public health experts, and we really didn't have a good sense of where and how some of the other groups that we were identifying really contributed to the issue of antimicrobial resistance. And that led to another project funded by the Canadian Safety and Security Program to better understand antimicrobial resistance using a complex adaptive systems approach. Essentially, what we did was invite people from different disciplines from across the country to participate in focus group discussions on antimicrobial resistance. And we purposely did not invite people like ourselves who were normally engaged in those AMR discussions. People like veterinarians and physicians, public health experts, or epidemiologists. We said we didn't want to hear from you. But we did want to hear from lawyers, food banks, community activist groups, producers, not the producer organizations, and a wide variety of other disciplines as well. And so we sent out a bunch of emails recruiting people to come and talk with us about antimicrobial resistance. And many wrote back and said, you must have the wrong person. I don't know anything about antimicrobial resistance. But once we sort of addressed their concerns and explained a little bit more about what we were doing, most people were willing to come and participate. And they were even willing to come to Guelph for a full day meeting. This was before COVID. So over about 18 months, we hosted 4 in-person focus groups. And that initial model that I showed on the previous slide is where we started the conversations. And this is where we ended the conversations with a much bigger and more complex system than our group of vets and public health experts had created. And on top of this one, there were about half a dozen overarching factors that we couldn't really place at one particular node on the system. And those are things like power and governance, climate, media, leadership, those types of ideas. But this work didn't stop in Canada, and we have since repeated a similar process in 2 other locations as part of our broader AMR resilience project. And so this work was funded by JPI AMR through the Canadian Institutes for Health Research. And similar to the Canadian pilot, we applied participatory methods to better understand the system dynamics that generate AMR in different places, specifically in the Swedish food system, and we did those focus group discussions in Sweden, and the Malaysian or Southeast Asian food system, and we hosted those conversations in Malaysia. Oops. But in addition to just sort of creating those messy, fuzzy, complex adaptive systems, we took it a step further and tried to identify factors contributing to long-term AMR intervention success. So we hosted this second series of workshops, again in Sweden and Malaysia, but this time we had to do it online because of COVID and we couldn't travel. but we recruited participants from among those who had already participated in building those big, messy system causal loop diagram maps. And we asked participants to explore how 2 interventions were able to combat AMR in 2050 under a changing climate. And at the end of this process, we created some narratives of alternative futures to describe how these interventions were successful. And to do this, we used a scenario building approach and basically asked participants to imagine that they were living in the year 2050. The world had successfully solved the AMR crisis in spite of a worsening climate through implementation of effective interventions. And what we wanted to hear from them was what needed to be in place in order for success to happen. As part of the workshops, we played a video that some summer students of ours created that described what the world could look like in the year 2050 to help situate the participants, to get them thinking kind of outside of their current setting and context. The videos were unique to Sweden and Malaysia because the effects of climate change are expected to be different in those 2 different locations, and because some of the interventions would be implemented a bit different, and some of the factors for success are likely a bit different too. We pre-selected 2 interventions that were identified from our broader AMR resilience project team and topped ranked by our group as potentially promising. And those 2 interventions were taxation at the point of antimicrobial sale and infection prevention and control. And we left it vague like that. We didn't provide any specific details. We just said we did taxation and it worked, and we did infection prevention and control and it worked too. And for time, and because the results of the Southeast Asian workshop are not yet published, I'm just going to quickly sort of walk through 3 alternative future scenarios that we built from the Swedish online workshops. In the first scenario, we've called tax burnout. Participants explored taxation at the point of antimicrobial sale and determined that it would be a low impact intervention, primarily because it created and exacerbated inequities among lower socioeconomic populations and developing countries in terms of access to antimicrobials. In the second future scenario, called addressing the basics, participants explored infection prevention and control measures and identified this one as a high impact intervention. And the reasons were that it would help reduce antimicrobial use by reducing the occurrence of disease, and it would contribute to achieving the Sustainable Development Goals, which participants said was essential to tackling the inequities underpinning both antimicrobial resistance and climate change. They also described some key features of 2050 that made this possible, including a paradigm shift where countries work together and society valued health and well-being over economic profits. I'm not sure how realistic it is, but that was what needed to be in place in order for this one to be successful. And it was in these conversations that a third narrative sort of emerged. And it may have been as a result of when these focus groups were being held, sort of in the fall of 2020. But in this future, participants described a world where nationalism and protectionism prevailed, with countries moving production of strategic industries like pharmaceuticals, food, and energy production closer to home to reduce supply chain interventions or interruptions. And participants felt that this would create walls between nations and would derail any of the advances that had been achieved in the addressing the basics scenario. And before I leave the section of this talk on antimicrobial resistance, I just want to highlight a few kind of takeaway messages. One, AMR is super messy and a wicked challenge. There are many pathways through which it develops, spreads, and impacts humans, animals, and ecosystems. Because of this complexity, we need to engage non-traditional stakeholders and perspectives to co-develop some new methods to better understand antimicrobial resistance, identify interventions, and evaluate how and where the impact of those interventions may be felt. And we need to shift away from our more reactive interventions that target direct drivers of resistance and use to consider and explore actions that affect more distal causes of resistance. So those sort of root causes of causes. And to me, this links back to health and the need to promote health across all species to support more resilient systems that are able to withstand some of the threats that are already sort of on us and are looming in the future as well. So I'm going to change gears now and walk a similar path, but in a wildlife context. So while working at both the Center for Coastal Health and with CFARS, I did some work with the Canadian Wildlife Health Cooperative in a variety of different capacities, and I still work with them today. The Canadian Wildlife Health Cooperative is essentially a network of wildlife pathologists and other experts working at 6 regional centers across the country who use surveillance, investigation, and research to assess wildlife disease status and work to find solutions. And so we're moving back a bit away from that focus on health that I think we got to in antimicrobial resistance back to more diseasey focus, at least for a moment. Much of my work at the Canadian Wildlife Health Cooperative has been in the area of surveillance. And we kind of have 2, I think of anyway, different types of surveillance activities. One is this idea of sort of just general scanning surveillance, where we have carcasses that are submitted to one of our regional centers for cause of death determination. And through this program, we see a variety of species, and we can track sort of trends in wildlife mortality over time. But a lot of my activity was taken up by more targeted surveillance initiatives, particularly for various infectious diseases of importance to wildlife specifically. So things like white nose syndrome and chronic wasting disease. Other diseases that also had an impact on domestic animals. So in my mind, that might be avian influenza here and chronic wasting disease in our farm cervid populations. And a third category of zoonotic agents that would also have an impact on human health. So things like West Nile virus and avian influenza as well, potentially. And I'm going to spend a little bit of time on avian influenza. It's the program that I have spent the most time with over the past 15 years. And we've tested a good number of birds during that time and detected some viruses. You can see there the live bird surveys. Those are birds that are caught, usually for other purposes, for banding activities. And then we would swab them for avian influenza. And you can see there that we have a fairly high proportion that routinely test positive, about 15% over that 16-year time period. And this is probably because most of those activities target waterfowl, so ducks and geese. And most of that surveillance happens in the late summer and early fall when birds are on their southward migration. And this is when we expect to see the greatest proportion of birds carrying avian influenza. And so we had higher levels of positivity in our samples from live birds. That's compared to the dead bird surveillance activities that happen year round, where any species of bird can be submitted and tested. And we see roughly about 1% of birds, dead birds submitted that have tested positive for avian influenza virus. I do want to draw your attention that these numbers are not reflective of the current highly pathogenic avian influenza outbreak that is going on in Canada and in the US and around the world. And the avian influenza in circulation today is quite a bit different in that it is not just, we're not only detecting it in our wild bird species, but it's also causing wild birds to get sick and to die. And this is not what we've seen in the past. Usually wild birds carry the virus, they don't get sick with the virus, and they just pass it on. And what we worry about is that transmission between wild birds and domestic poultry. But something about this new virus is a bit different. Although there have been very few human cases associated with the currently circulating strain of avian influenza, all of them mild, there have been die-offs in other mammalian species, including foxes, harbor and gray seals, mink, skunk, and bears in Canada, and a variety of other mammalian species affected worldwide. And while successful on many fronts, the avian influenza program in Canada, and I would argue internationally, has not really helped us predict where or when outbreaks of avian influenza will occur. And there are many reasons for this, probably including, or among them, a low sample size compared to the actual population at risk. That sampling is not evenly distributed across the country or around the world. And it often takes place far from major poultry production locations. And so even if you find a positive bird, what do you do with that information? What does it mean to a producer? If I detect avian influenza here in Guelph, and you're a poultry producer in Alabama, what does that information mean to you? How are you going to use that information? Similarly, what is public health going to do with that? How are they going to, what messages are they going to put out? Other questions have been raised, such as how early is early enough to be helpful to poultry producers? How close does a detection need to be to inform behavior change? And many others. And these questions are particularly pressing right now as we see unprecedented levels of highly pathogenic avian influenza activity around the globe. So how can we make our surveillance more useful? One option is to start using more and different data and information sources, to shift from a disease or virus detection model to a more health intelligence model. And so that's what we set out to do as part of another pilot project, to sort of pull different types of data together in hopes of improving our surveillance and ability to anticipate threats, and especially how the threat level would change over time. We weren't interested in looking at how the threat level changed over space or across space, and we didn't want to compare different locations. And so this pilot study we did in southwestern British Columbia, so in and around the Vancouver area, and in central Alberta, sort of between Calgary and Edmonton, if you know some of your Canadian cities. And we know those two areas are different. Vancouver is kind of warm and wet and on the coast. Alberta has more of that sort of inland Canadian prairie climate that has very cold, dry winters and very warm, drier summers, at least traditionally. And we wanted to take sort of diverse information sources about the environment, the birds, and the pathogen from multiple different sources to build a more full sort of understanding of potential threats posed by avian influenza. And so what we wanted to do was take information like this, so you can see some from our CWHC surveillance program, some just anecdotal reports of wild birds being in the area, some weather events over time, and just location of where we know avian influenza to be circulating internationally. We wanted to take information like this and turn it into signals like these. And our pilot kind of worked. And this is the figure for Alberta, and we can see that there's a change in threat level in and around sort of the end of October, early November. So about a month ago, this is earlier data or from another year, but around the same time period. And the main driver of that shift was the presence of waterfowl on the landscape, which is sort of that brownish, yellowish bar there in the middle. And so we can see that the threat appears to be higher in the early fall, and then it drops sort of in early November, at least in the Alberta pilot site. I don't have a picture of the BC pilot site, but there was no sort of solid break like this. We didn't have a time or a place where we could say to poultry producers that the risk was going down. And this is probably speaks to the differences in the climate around in Vancouver and in Alberta. And again, I mentioned those before. Vancouver tends to be warmer all winter long. There tends to be wild waterfowl present throughout the winter in close proximity to poultry farms. And so perhaps we don't have the right indicators for British Columbia, or maybe we had insufficient data about some of those indicators. So there's still some work that we need to do in this area. And that brings me to kind of where I am now. And in this One Health faculty position at the University of Guelph. And I want to start just with One Health, and I'm sure this figure is familiar to most of you. And it does a nice job, I think, of illustrating both the concept of One Health and how One Health can be applied or practiced. For me, the figure highlights the need for collaboration between human, animal, and environmental disciplines. It recognizes the need to tackle problems at a variety of levels. And it highlights sort of the ultimate goal, and that being to achieve better health for all, for humans, animals, and ecosystem. I joined the university relatively recently, and over the past few years, a lot of our time has been spent developing new One Health training programs, both at the graduate and the undergraduate level. And I have to say, there's nothing like having to teach or develop new educational programs to really force you to think about, what does One Health mean? What do we want to do? How are we going to teach it? What do we want our students to learn? And this is kind of where I've landed. That One Health is first and foremost about health, not about disease. It's about the interdependencies between human, animal, plant, and ecosystem health. And it recognizes an urgent need to do things differently and better. For me, anyway, and I think for many, the concept of One Health, which I think is reflected in those interdependencies and connections that we're starting to recognize a bit better. I don't think this area is particularly hard to grasp, that, you know, your health, my health is dependent and connected with the health of the world in which we live. But what I do think is much harder, at least what I struggle with a whole lot more, is about how do you actually do One Health? How do you put it into practice? How do you implement the approach? And I think I've shown you some of the things that I've often done and others have often done in terms of putting different data sources together and just highlighting them and looking for connections. And I showed you some of that with that safety fear story of a few minutes ago. But I hope I was also able to highlight some of the other ways that we can put One Health into practice. And for me, that a lot of that is about enabling conversations, about listening to other perspectives, and recognizing that no one individual or discipline is going to be able to tackle a lot of these challenges ahead of us. So I mentioned that we've started a bunch of new One Health training programs, and these are the 3 new programs that we've launched to date. So the first was the One Health Collaborative Specialization, and essentially this is like a minor at the graduate level. And so students enrolled in any one of the participating programs, and they can be in any department across the campus, do sort of this added collaborative specialization. So they have to demonstrate that their thesis has a One Health or is incorporating elements of a One Health approach. Somebody on their advisory committee has to be One Health affiliated faculty, and they are required to complete 2 new One Health courses, one on approaches to research in One Health and another one on One Health seminar. And really what we've done there is sort of in the approaches to research course, we're trying to sort of emphasize, you know, systems thinking, collaboration, transdisciplinarity, some of the fundamental elements of One Health. And then in the seminar course, we're trying to provide an environment where students can put that into practice. And I have to say it's one of the most fun courses I've had the pleasure of teaching or instructing. And it provides opportunity for students to discuss, to meet with faculty from other departments, to get to know students from other departments that they wouldn't necessarily meet. And it's something that I worry that we're losing a bit in our higher level academic institutions. And COVID certainly didn't help with this, but I'm pretty excited about the seminar course and how positively students are participating in it. We also have a new for us, combined DVM MPH program. There are a ton of these programs in the US, but this is the first formal one in Canada. And it essentially enables veterinary students to complete a Master of Public Health in a reduced number of semesters. And the most recent program at the University of Guelph is a Bachelor of One Health, and it just launched this fall. So the first group of students is just finishing their first semester. And we spent quite a long time developing this program. And we developed the program and then we decided what the degree would be. And it really didn't meet either a Bachelor of Arts or a Bachelor of Science. And so it's simply a Bachelor of One Health. And the students are required to take a variety of sort of traditional science courses, as well as social science and arts courses, some of which are required and some of which are elective. They then are sort of streamed into one of 4 areas of emphasis that enables them to sort of delve a little bit deeper into a particular area of One Health. And I'd be happy to talk a little bit more about that, but that's really not the focus for this talk. So I'll leave it there. But if you are interested in any of these programs, there's information about all of them on the University of Guelph website. But in developing these programs, we really needed to do some thinking, coming back to where my thoughts were. Sorry, I got off track. we really needed to think about what we wanted students to do. And so we set about developing and drafting some core competencies for One Health education. And these are those intellectual, personal, social, and emotional proficiencies that all students should have or be able to exhibit at the end of their program. And we looked to the literature for help, and we asked several colleagues for input as well. And through this process, we identified sort of 5 core competencies: holistic understanding of health, leadership and collaboration, problem solving and critical skills, knowledge mobilization and communication, and professional and ethical behavior. Each of these core competencies then has some enabling competencies underneath and sort of the lighter gray box. And we've also grounded all of those in sort of that base framework that I mentioned earlier, that One Health is about health, interdependencies, and this need for doing better and enabling positive change. One of the elements that is more and more important to me, I think, comes under the doing better and making positive change foundational element. How do we encourage students to reach out and talk to each other, to ask questions, to be willing to answer questions that others have, and be willing to try new things and risk getting it wrong? Failure is not a bad thing. It can be one of the best learning tools we have, and yet we often penalize students for trying something and failing at it. So how can we sort of change or adjust some of our education and training programs to enable students to do this? Sorry, slides keep advancing. And that's one of the things that we're sort of struggling with right now here at the university, is about how to create a safe space where if we keep doing the same things, we're not going to sort of find new solutions. So we need to be willing to try new things, to get it wrong, to adjust and try it again. And that brings me to where I am now in this One Health faculty position at the University of Guelph. Where am I? Sorry, I've totally lost my train of thought. I could probably talk about epidemiology and One Health for ages, and I'm not going to do that, but I do want to leave you with a few final thoughts, and then hopefully we can have a bit of a dialogue and some questions. So just recognizing that over the past 20 years, global health challenges have both become more apparent and more urgent. You know, we can think about SARS and SARS-CoV-2. We can think about mpox, antimicrobial resistance, climate change, biodiversity loss, growing inequities, and the list goes on. Each of these on their own have significant health impacts on animals, including humans, ecosystems, and society. But when they occur together, our collective ability to cope is compromised. And the compounded nature of health threats today demands more time and resources than currently exist in our health and related systems. We simply don't have the human or financial resources to address each challenge individually. And as a result, many government and non-governmental agencies are having to grapple with multiple threats at the same time. This is forcing them to trade off things as basic as food security and nutrition, or employment and environmental protection. But the multiple health threats that we are facing today are not at all independent of each other. There are shared root causes that connect and drive many of these challenges, things like poverty, hunger, climate change, and others. And most of those are addressed in the Sustainable Development Goals. And the work I presented earlier on antimicrobial resistance, I hope really served to emphasize those linkages and the need to address some of these core underlying root causes. Until people around the world have access to basic hygiene and sanitation, food, and education, our efforts to reduce use and resistance are unlikely to be effective or sustainable in the long term. And to get ahead of these ongoing extraordinary social and environmental changes, we really need to explore these new partnerships, tools, and approaches. We need to do better and inspire positive change so that all species, places, and generations at least have a chance to achieve their full health potential. And our current approach to problems is, I believe, how we arrived where we are today. And so we need a different, perhaps kinder approach to respond to today's challenges and get us where we want to be tomorrow. The need for a different approach is creating new opportunities to rethink leadership and how decisions are made. especially how trade-offs are recognized and handled in decision-making. And as we strive to cope with simultaneous pressures, particularly responding to immediate crises, there will be people, animals, and places that benefit immediately, while others who may be harmed, at least in the short term. And new practices and systems are needed to recognize when these trade-offs happen, who or what is winning or losing now, and what the consequences of those decisions could be in the future. Whatever the approach, the trade-offs need to be confronted before irreversible social or ecosystem damage occurs. And it's this idea of trade-offs that I think offers some really neat opportunities in epidemiology. How do we figure out what those trade-offs are? How do we connect seemingly disparate interventions with impacts way far downstream that we didn't necessarily predict? And to do better and support collaboration across sectors, we need spaces, real and virtual ones, and occasions to bring different voices together and learn from each other. This is easier to do when we have political will and there's public pressure also. And essentially what is needed is a common understanding of the problem. And I recognize this is a bit of a chicken and egg situation. We need a shared understanding to come together, but often we need to come together to develop that shared understanding. But I see this as an opportunity to really try to develop some new tools and approaches to carry out research to better understand what works or doesn't work, who it works for and who it doesn't work for, and in which context or setting do different interventions work best. And I believe one of the biggest needs is some evidence that collaboration and participation contribute to better decisions and health outcomes, because I worry that right now we're doing that, or at least I'm doing that on faith and not with evidence. Just earlier this year, we tried to outline some of the steps needed to get started in a policy brief that we wrote for the Royal Society of Canada on One Health. And this was part of a series of publications related to the Canadian response to COVID-19. And in that document, 3 of the key action items we called for were establishment of a One Health Council that would include representation beyond disciplines in government, and that wouldn't report only to a single minister or a single agency. That One Health Council would help oversee development and implementation of a One Health action plan that would really help sort of improve awareness and understanding and how to do One Health in a Canadian context. And finally, we called for establishment of a One Health Centers of Excellence to connect different groups with different knowledge and expertise, to leverage and make better use of existing data, and to provide space for collaboration and knowledge exchange. My vision for the future is one of equity and reciprocity, where people, animals, and ecosystems are able to cope with unprecedented changes without compromising their ability to respond in the future. Equity is not just about people, and I think often we frame it that way, but it also spans multiple species and multiple generations. Empowering people to protect their own health, the health of other people and animals, all while protecting the environment, will require new policies and practices to improve health, equity, and sustainability, all at the same time. Confronting the trade-offs that I talked about earlier will help ensure that health opportunities exist today and tomorrow as well. And while there will be trade-offs, by working together, I hope that the negative impacts of decisions can be balanced out and borne by different groups and places at different times. For me, this is at the core of reciprocal health, which occurs when we take care of each other, our neighbors, and the places where we live in, to help reduce vulnerability and promote resilience. It doesn't mean that everything needs to be healthy or resilient all of the time. That's not a fair expectation. And reciprocity involves giving and receiving, and both of those acts require practice to be done well. Around the world, success of health promotion initiatives, such as access to safe, clean water and vaccination programs that direct resources to upstream determinants of health, have been shown to be efficient and effective, whereas responding to diseases once they emerge is much more difficult and very costly. And by switching our attention away from controlling and preventing existing threats to how we can improve health overall, has the potential to benefit all species and ecosystems that sustain us. And so those last few slides were a bit sort of a rant, or something that I feel quite strongly about, and something that I'm not quite sure how to that we've done very well in building into our veterinary training programs or some of our other health building programs either. And that's as far as I've gotten in this journey from disease to health. I continue to struggle with the questions of what can I do and how can I make things better? And I have to admit, I don't really know the answers to that, but I'm pretty convinced it comes from asking questions, talking to friends, colleagues, and strangers alike. And maybe that's a good place to end. And I'd love to hear your thoughts on this and how your journey is progressing as well from disease to health.